Hello, my name is Dr. Ian Staymeyer. I'm an emergency medicine physician from Salinas Valley Memorial Hospital, and this is Vanity Segurero, who works with me as a registered nurse in the emergency department at SVMH. So there's a couple of reasons why we do central venous pacing. The most common one is for third-degree heart block, but there are other reasons as well. Basically, if they're very symptomatic in bradycardia, sick sinus syndrome, you want to put in a pacemaker. There are a couple other reasons to do it as well. If their heart's beating very fast and tachyarrhythmia, VTach, atrial flutter, you can do this as well. But to be honest, most of the time we'll just cardiovert or give some sort of medication. The vast majority of reasons is just for symptomatic bradycardia. So the next part we'll talk about setting it up.
So the physician lets you know that he needs to float a transvenous pacing catheter. So I'm going to show you what equipment we need to gather. The first thing you'll go ahead and grab is this, it's actually a central line placement kit. But it's just the quickest and easiest way to get things. We're not going to use the introducer in here, or they aren't going to use the introducer in here, but it's the quickest and easiest way to get the scalpel, the betadine, the lidocaine, anything else that's needed. There's a gown and things in there for them. All of this is located in the trauma omnicell as well. The next thing that you're going to want to make sure and grab is the pulse generator. It comes in the black pouch, so we're going to go ahead and grab that. And in the black pouch with the pulse generator, there is also the disposable extension cable that's right here in the pocket. You're going to want to also make sure that there is a new battery, because you will need to place the new battery as well. The other things you're going to need is the fast cath introducer. This is the only introducer for our pacemaker catheter that this facility uses. It's the only one that fits, and it's got a screw to tighten the catheter in place at the end once it's placed. Here's our bipolar pacing catheter. Currently our facility does not have the ones with the balloons, but they're looking at changing that and getting some soon. The other things that we're going to need are our positive pressure connectors. We'll need 2 of those. We'll also need our bio patch, and these are just things to dress the central line once it's in place. Your flushes, as well as your tegaderm. Now that you've seen how to set up for the transvenous pacer for the physician, we're going to go ahead and grab the pulse generator. And the first thing you want to do when you grab the pulse generator is we're going to change the battery. So the way that you open it is you push it on both sides here. There may or may not be a battery in here. Even if there's a battery in there, you're going to change it. For demonstration purposes, I'm not going to change it though today. The next thing you want to do is, we're going to open this, is you're going to turn the pulse generator on. You'll see that it's on by the green blinking light in the upper left-hand corner of the pulse generator. So you're going to start from top to bottom. The first dial is the rate. You're going to set the rate at 100 unless the physician otherwise specifies. Then the next one is the milliamps and the output. And we're going to go ahead and set the output to 20 while we float the wire. Later, after the wire is in place and the physician specifies, we can go ahead and check the sensitivity threshold. At that time, we're going to go ahead and back off on the sensitivity until we've lost consistent capture, meaning we've lost where you see a pacemaker spike in a complex consistently, that's capture, where you lose that consistently. So once you've lost that, say you lose it at 2, you want to double it and put it at 4, which I would just bump it up to 5, or if you lose consistent capture at 5, go ahead and bump it up to 10, and that's your sensitivity threshold. And the next thing down here is the sensitivity. Over here is, on the far right, is 0.5. That is the most sensitive. That is where the pacemaker wire will sense even the smallest cardiac activity. And if you have it over here at 20, that's the least sensitive. The pacemaker wire will only sense the very large cardiac activity or cardiac output. For our purposes, the patient's unstable, they're crashing, so we put it down here over on the far left to asynchronous.
Okay, so now we're going to place the transvenous cardiac pacer. We're going to use the central line kit and basically start the procedure like you would any central line. The only difference is you're going to use this wire, not the wire from the central line kit. It's the fast cath hemostasis introducer. It's a 6 French and it's a little J wire. And basically, once you get the aspiration needle and you put that through, let's say it's put through like that, then you're going to take the special port, which has its own dilator, and it has one port for medicine or fluids. And you basically put that through. It's important that you loosen this port up here. So once that's through, then you push the dilator and the catheter through as you pull the wire out. And then once it's about halfway, you can actually pull the dilator and the wire out and finish putting in the port completely. So now that the port is in, just imagine if it is. Okay. Then you take your pacer wires, okay, pacer wire, and I just want to draw attention to these notches. So each notch is 10 centimeters. 20, 30, and then the big one is 50, okay? So you put the wire through the port like this, and at about 20 centimeters is when the wire is completely through. Now we don't have a Swan-Ganz balloon catheter yet. So it's important that you put the memory of the wire facing to the atrioventricular valve as it goes through the valve into the right ventricle. It'll just kind of guide its way through. So as you can see by this diagram, that at 20 centimeters it's just above the right atrium. 30 centimeters you're pretty much in the atrium. 40 and 50 you should be in the ventricle by now, and if you're not getting capture, that means you bypass the right atrium completely and you're actually in the inferior vena cava. By this time you'll actually probably see that their diaphragm would be twitching and their body would be twitching if you have the pacer on. Once that's in, you take the leads here, see there's 2 ends, and you pass it off to the nurse. I'm going to pass it to Vanity here. Now that's not sterile, and she's going to connect it to the pacer box. Good. Once that's done, then I lock this port, so I tighten this port back down. Now it's not going to move. And then once that's done, you suture it in place, place the tegaderm, and then you're done.